Hello, dear future nurses, current nurses, new graduate nurses who are looking for more information about the management of care for a patient with immunity disorder. In this section or in this lecture, I'm going to talk about HIV infection, AIDS, and viral hepatitis. I'm Tara Sorabi from Montgomery College, a professor who is teaching the first med-surg and second semester student. Would like to welcome you to this lecture and continue the lecture. So basically what we are talking and what is the outcome for this lecture is that our student to describe the mode of transmission of human immunodeficiency virus infection and strategies that they need to take to prevent from contamination. We want our student to describe the host viral interaction during primary infection with HIV, explain the pathophysiology associated with the clinical manifestation of HIV and acquired immunodeficiency syndrome, AIDS, and describe the gerontologic consideration related to HIV/AIDS. The rest you can read by yourself, and we are going to make sure you all are able to compare and contrast different classification of hepatitis with regard to causes, prevention, risk factors, clinical manifestations, medical management, nursing management, including patient education and complication. You should be able to compare the various types of hepatitis and their causes, prevention, clinical manifestation, management, prognosis, and home health care needs for patients with viral hepatitis. Human immunodeficiency virus. First, let me talk about the basic function of immunity system. The basic function of immune system is to remove foreign antigens such as viruses and bacteria to maintain homeostasis. There are two general types of immunity: natural or innate and acquired or adaptive. Natural immunity or non-specific immunity is present at birth. Acquired or specific immunity develops after the birth. Each type of immunity has a distinct role in defending the body against harmful invaders, but the various components are usually interdependent. Let's talk about natural immunity. Natural immunity is non-specific, provides a broad spectrum of defense against and resistance to infection. The cells involved in this response are monocytes, macrophage, dendrites cell, and natural killer cell, basophils, eosinophils, and granulocytes. The early events in this process are critical in determining the nature of the adaptive immune response. Natural immune mechanism can be divided into two stages: immediate and delayed. Immediate is generally occurring within a minute and delayed occurring within several days after the exposure to agents. How the immune system regulates. The regulation of the immune response involves balance and counterbalance. Dysfunction of the natural immune system can occur when the immune components are inactivated or when they remain active long after their effects are beneficial. A successful immune response eliminates the responsible antigens. If an immune response fails to develop and clear an antigen sufficiently, the host is considered to be immunocompromised or immunodeficient. So basically, the body or immune system should be able to respond to the antigen. Now, talking about the acquired immunodeficiency or human immunodeficiency, which is an acquired immunodeficiency, can be developed due to a medical treatment, like if we have a patient that is having cancer or diagnosed with the cancer and receiving chemotherapy for any reason, or infection from agents such as, so basically go back. There are two types of acquired immunodeficiency. One is when it's medical, like chemotherapy, and the other one is when the agent such as human immunodeficiency virus attacks to the body and the body cannot respond to this. Advances have been made in treating HIV infection and acquired immunodeficiency syndrome or AIDS. However, AIDS remains a critical public health issue in communities across the country and around the world. Prevention, early detection, and ongoing treatment remains important aspects of care for persons living with HIV infection or AIDS. Let me see what else we have in here. I talked about early prevention and early detection. So, you're going over the mode of transmission. A human immunodeficiency virus is transmitted in body fluid, blood, seminal fluids, vaginal secretions, amniotic fluids, and breast milk that are contain infected cells. Higher amounts of HIV or infected cells in the body fluid are associated with the chances that the exposure will result in infection. So talking about the mother and baby, mother-to-child transmission of HIV may happen in utero and the time of delivery or through breastfeeding, but most perinatal infections are thought to occur after exposure during delivery. HIV is not transmitted through casual contact. Remember, transmission of the HIV is not through the casual contact. You can take a look in the chart 36 too to learn more about the mode of transmission. Blood and blood products also can transmit HIV to recipients. However, the risk associated with transfusion has been almost eliminated as a result of voluntary self-deferral, completion of detailed health history, extensive testing, heat treatment of clotting factor concentrates, and more effective virus inactivation methods. Donated blood is tested for antibodies to HIV-1, human immunodeficiency virus type 2, or retrovirus identified in 1986. So additional testing also has been performed for the blood transfusion, so it is eliminated. Talking about the risk factors, nurses need to help in effort to prevent HIV infection by educating how to eliminate or reduce risk associated with HIV infection and AIDS. Prevention of HIV infection is achieved through a behavioral intervention, and it has been effective in reducing the risk of acquiring or transmitting HIV by making sure that the people have the information, motivation, and skills that is necessary to reduce their risk. Next is HIV testing, because most people change behaviors to protect their partners if they know they are infected with HIV. And next is linkage to treatment and care, which enables individuals with HIV to live longer, healthier lives, and reduce their risk of transmission of HIV. Talking about the CDC, CDC has, through the HIV/AIDS prevention research synthesized project, provides information about evidence-based behavioral intervention that can be used in a number of settings with target population. Strategies to protect against infection are outlined in Chart 36. Make sure to read the chart 36-3 to learn about the strategy that we need to take to protect against the contamination. So prevention, as I said in the previous slide, education to how to eliminate. So prevention education is talking about behavioral intervention, HIV testing, and linkage to treatment that I explained in the previous slide. Now, the strategy that we need to take to protect against HIV infection. Go back again to chart 36, read those strategies. It is important to have a consistent and correct use of condoms, medical male circumcisions, female condom, harm reducing framework for people who inject drugs, needle exchange, may use bleach to clean the needles and syringes if they are using the same needle and syringe and sharing it. Avoid sharing needles and syringes. A standard of precaution is very important. Going back to the strategies to protect against HIV is reproduction caution. Maybe if the partner of any partner of a couple, if it's infected, so it's better if they want to have a baby to artificially be inseminated. Benefit of ART or antiretroviral treatment is important, and refrain from breastfeeding. So if a mother is positive, they should refrain from breastfeeding to protect their baby from contamination. Talking about LGTB community, LGTB youth are at high risk for HIV infection. The people should remain judgmental in educating about the prevention to them and make sure they receive enough information for about the preventive measures. Standard precaution is very important. Implementation of appropriate hand hygiene measures remains the most effective measure to prevent transmission of organism. To reduce the risk of exposure of healthcare workers to HIV, the CDC developed standard precautions which are designed to reduce the risk of transmission or pathogens. Standard precautions are used when working with all patients at all healthcare settings, regardless of their diagnosis or assumed infectious status. Don't forget, you do not need to know if a patient is HIV positive or not. You always have to follow the standard precaution or universal precaution. You can read the chart 36-5 for more information. So hand hygiene is important, and post-exposure prophylaxis is very important. I'm going to talk a little bit about the post-exposure prophylaxis because you might, as a student nurse, need or want to know, so if I get infected, what should I do? All right. So post-exposure prophylaxis includes taking antiretroviral medication as soon as possible, but no later than 72 hours. After possible HIV exposure, 2 to 3 drugs are usually prescribed, which must be taken for 28 days. Healthcare workers who are exposed to a needle stick involving HIV-infected blood in a healthcare setting have a 0.23% risk of becoming HIV infected. But still there is a risk. The risk of infection due to occupational exposure is very low. As of December 31st, 2013, 58 confirmed occupational exposure to HIV and 150 possible transmission had been reported in the United States, and telling you the truth, only one confirmed case has been reported since 1999. But there is a possibility, low possibility, but you want to make sure you protect. Occupational exposure is considered an urgent medical concern and should be managed immediately after possible exposure. So as a student nurse, what you're going to do, you're going to call or inform your clinical instructor. Now, if you work in a facility, they will tell you who should you contact as soon as possible, but CDC has an outline or protocol for that. The CDC is suggesting that these post-exposure guidelines be followed after occupational and other exposures such as sexual assault. Take a look at chart 36.6 that provides you the strategies and emphasizes the need for quick action. The phone number for the Health Resources and Service Administration post-exposure prophylaxis hotline is listed in the resource section at the end of this chapter. Make sure to find them. The hotline is answered by a healthcare provider. So make sure you are aware or just save these numbers in your phone about this. So going to the question. So antiretroviral medication as post-exposure prophylaxis for healthcare workers are started within how many hours? Yes, within 72 hours, no later than 72 hours. So 72 hours is the answer. You can see it's highlighted, but I don't know if you can see very well. Option B is the correct answer. So you want to make sure you act as soon as possible, and anybody who is infected or think is infected should receive this antiretroviral medication for 28 days. So they're talking about the pathophysiology. Because HIV is an infectious disease, it is important to understand how HIV integrates itself into a person's immune system and how the immune response plays a pivotal role in the course of HIV disease. This knowledge is also essential for understanding medication therapy and vaccine development. Viruses are intracellular parasites. HIV is in the subfamily of lentriviruses and is a retrovirus because it carries the genetic material in the form of ribonucleic acid RNA rather than deoxyribonucleic or DNA. So make sure to understand the pathophysiology, and HIV virus targets the cell with CD4 plus receptor, which is one type of the T cells which are expressed on the surface of the T lymphocytes, monocyte, dendrite cell, and brain microglia. So basically the target is CD4 receptors. Now, if someone doesn't have that receptor, won't be infected. But most people have that receptor in their T lymphocytes and they can be infected. Okay, let's talk about the steps in life cycle of HIV. What does it do? How the virus duplicates in the body. Before I go over this, I recommend you to watch the YouTube clip that I posted on Blackboard for you guys. Watch it, because after watching this, when you listen to this lecture, you will have a more understanding of these steps and processes. So basically, my recommendation to you is take a look first. In the step of attachment or binding, which is the first step, the GP120 and GP41 glycoproteins of HIV bind with the host uninfected CD4 receptor and chemokine co-receptors, usually CCR5, which result in infusion or fusion of HIV with the CD4 cell T cell membrane. You do not need to memorize these glycogen co-proteins or CCR5, but you need to know the target cells are CD4 plus T cell. So they enter to CD4 plus T cell, not CD8 plus T cell. We have different T cell in the body, but this is the CD4 plus T cell membrane. So they enter to this CD4 T cell membrane, which are the defender of the body. So in the step of uncoating and fusion, only the content of HIV's viral core, which are 2 single strands of viral RNA and 3 viral enzymes, reverse transcriptase, integrase, and protease, are emptied into the CD4 cell. So they start fusing themselves into the CD4 T cell. The next step is DNA synthesis. As I said, please take a look, watch that video while you're reading this or listening to this or taking your notes. It will make more sense for you. So at the DNA synthesis, HIV changes its genetic material from RNA to a DNA through action of reverse transcriptase, which results in double-stranded DNA that carries instruction for viral replication. That means that's how they synthesize themselves and replicate. Now talking about the integration of these steps, new viral DNA enters the nucleus of the CD4 plus T cell, and through action of integrase, is blended with the DNA of the CD4 plus T cell. So it binds or blends with the CD4 plus T cells DNA, which results in permanent, lifelong infection. Prior to this, the uninfected person has been only exposed to not infected with HIV. With this step, HIV infection is permanent. So basically, when we talk about the post-exposure treatment, the medication that are given after exposure prevents from these 3 steps and prevents from infection. So that means the medication are blocking those steps to prevent from infection. That's the reason it is important to receive the medication within 72 hours. Now, when the patient is infected, it goes to the transcription. When the CD4 plus cell is activated, the double-stranded DNA forms single-stranded messenger RNA or mRNA, which builds new viruses. So once someone is infected and gets to the transcription step, then patient is or individual is infected. Now going to the translation step, the mRNA creates chains of new proteins and enzymes, which is called polyproteins or polyproteins, that contain the components needed in the construction of new viruses. So going to the step of cleavage, the HIV protease enzyme cuts the polyprotein chain into the individual proteins that make up the new virus. So then goes to the budding, new proteins and viral RNA migrates to the membrane of the infected CD4 plus cell, exists from the cell, and start the process all over again, attacking to other CD4 cells. Talking about the stages of HIV infection, there are 5 stages of HIV infection based on clinical history, physical examination, laboratory evidence, signs and symptoms, and associated infection and malignancy. The period from infection with HIV to the development of HIV-specific antibodies is known as primary infection. Because as we talked about, when a foreign agent enters to the body starts to produce antibody, right? So that takes time for antibody to produces in the body. So it is called the primary infection or acute HIV infection. Usually in the past, it was known as the window period, and it's part of stage 0. In the acute HIV infection, it is the interval between the appearance of detectable HIV RNA and the first detection of antibodies. Its duration also depends on the design of the antibody immunoassay and the sensitivity of the immunoassay during seroconversion. Initially, there is a period during which those who are HIV positive test negative on the HIV antibody blood test. So that means their test is positive for HIV, but still when they test them for antibody, it doesn't show that the presence of antibody. These people who are infected and doesn't show the antibody, they are highly infectious because their viral loads are very high. About 40 to 80% of patients develop clinical symptoms and non-specific viral illnesses. So in these cases, usually the patient shows or has some symptom of cold, flu-like symptom, but mostly they don't. And usually these symptoms last from 1 to 2 weeks. After 2 to 3 weeks, let me see if I'm following this, CD4 cell count. Yeah. After 2 to 3 weeks, antibodies to the glycoproteins of the HIV envelope can be detected in the serum of people infected with HIV. But most of these antibodies lack the ability to totally control the virus. So antibody is what? What is doing? They're controlling the virus. They're controlling the microbes, anything, any lethal agent that enters to the body. But at this time, they cannot do this. By the time neutralizing antibodies can be detected, which is stage 1, HIV-1 is firmly established in the host. Primary or acute infection is characterized by high levels of viral replication, widespread dissemination of HIV throughout the body, and destruction of CD4 plus T cells, which leads to dramatic drop in CD4 plus T cells count. Normally, what the normal numbers are for the CD4 plus T cells in a normal individual, with non-infected individual, not normal, is 500 to 1500 cells per millimeter cube of blood. The host response to the HIV infection through a CD4 plus cells response that causes other immune cells, such as the CD8 plus lymphocytes, to increase the killing of infected virus-producing cells. The body produces antibody molecules in an effort to contain the free HIV particles and assist in their removal. During this stage, the virus is widely spread in lymphoid tissue, and a latent reservoir within resting memory of CD4 cell is created. The amount of virus in the body after the initial immune response subsides is referred to as a viral set point. This viral set point results in an equilibrium between HIV levels and the immune response that may be elicited. This can last for years and is inversely correlated with disease prognosis. The higher the viral set point, the poorer the prognosis. And this is the time that the people have no sign or symptom of disease. So talking about the stage 1, after the viral set point is reached, a chronic stage persists in which the immune system cannot eliminate the virus despite its best efforts. This set point varies greatly from patient to patient and dictates the subsequent rate of disease progression. On average, 8 to 10 years can pass before a major HIV-related complication develops. As you see, as I said, this is the stage 1 that is mostly asymptomatic. In this prolonged chronic stage, patients feel well and have few, if any, symptoms. Apparent good health continues because CD4 plus T cells levels remain high enough to preserve immune defensive responses. But over the time, the number of the CD4 plus cells continue to decrease. Talking about the stage 2, this stage occurs when CD4 plus T lymphocyte cells are between 200 and 499. So this is called stage 2. For stage 3 is when the count drops below 200 cells of blood, and at this point the person is considered to have AIDS, or acquired immune deficiency syndrome, for surveillance purpose. HIV disease progression is classified from less to more severe. Once a case is classified into a surveillance severity stage, it cannot be reclassified into a less severe stage, even if the CD4 plus T lymphocyte increases, which often occurs when a person receives antiretroviral treatment. Okay, continuing to clinical manifestation of HIV, as I said before, stage 1 is asymptomatic, and all the other manifestation or symptoms that the patient might need hospitalization are related to different opportunistic infection or infectious agent that attacks to the patient body and cause the infection in different system of the body. The first system that is always at risk for infection is the respiratory system. Usually the patient presents with the shortness of breath, dyspnea, cough, chest pain. Different disorders are manifestation with this HIV or AIDS, which one is a pneumonia that is called pneumocystis pneumonia, which is caused by Girovetti, usually it was called Caridi panel, an opportunistic infectious parasites, and that incident which attacks to the patient body. The most common manifestation of pneumocystic pneumonia are subacute onset of progressive dyspnea, fever, non-productive cough, and chest discomfort that usually worsens within days to weeks. In mild cases, pulmonary examination usually is normal at rest with exertion. Normal at rest, but with exertion, the patient will have tachypnea, tachycardia, and diffuse dry rails may be auscultated. Oral thrush is a common co-infection that you might see the symptom, which is appears with the fever, and in the most cases maybe predominant symptom. The other symptoms that with the respiratory disorder or pneumocystic pneumonia is hypoxemia, which is the most characteristic laboratory abnormality, along with the elevated lactate dehydrogenase level. Because clinical presentation, blood test and chest x-ray are not pathognomic for PCP, and because the organism cannot be cultivated routinely, histopathologic or cytopathologic demonstration of organism in tissue, bronchoalveolar lavage fluid, or induced sputum sample is needed for the definitive diagnosis. The other infectious disorder is called Mycobacterium avium complex. This disease, or MAC, is called MAC, M-A-C. Disease is a common opportunistic infection that typically occurs in patients with the CD4 T lymphocyte cell count less than 50 cell. So basically, if you have a patient with the symptom of respiratory disorder and the CD4 cells are higher than 50, usually around 200, you will know that the patient has pneumocystic pneumonia. Let me see. Early symptom for MAC may be minimal and can precede detectable mycobacteremia by several weeks and include fever, night sweats, weight loss, fatigue, diarrhea, and abdominal pain. A confirmed diagnosis of dissemination of the MAC disease is based on compatible clinical signs and symptoms coupled with the isolation of MAC from cultures of blood, lymph nodes, bone marrow, or other normally sterile tissue or body fluids samples. The next respiratory disorder is tuberculosis. That estimated annual risk of reactivation with tuberculosis among those with untreated HIV infection and latent TB infection is 3 to 16% and approximates the lifetime risk for individuals without HIV infection who have latent TB infection. TB disease can occur at any CD4 plus lymphocyte. It should not be CD4 plus. It could be occur at any CD4 plus lymphocyte or CD4 plus cells count, although the risk increases with progressive immune deficiency. Testing for latent TB at the time of HIV diagnosis should be routine, regardless of an individual's risk for TB exposure. Individuals with the negative diagnostic test for the latent TB who have a stage 3 HIV infection should be retested once their CD4 plus count increases due to antiretroviral therapy. Screening for symptoms like asking the patient for cough or any or the duration of the cough, which coupled with the chest X-ray is recommended to exclude TB disease in a patient with a positive skin test or interferon gamma release assay. Also, latent TB in person with HIV infection is treated with INH or isoniazid, supplemented with pyridoxine or aminoxine to prevent the peripheral neuropathy for 9 months, since it has proven efficacy, good tolerability, and infrequent severe toxicity. So these are the medication of choice: isoniazid or INH and pyridoxine for patient HIV positive patient and positive tuberculosis. Okay, gastrointestinal manifestation of HIV patient and AIDS includes loss of appetite, nausea, vomiting, oral and esophageal candidiasis, and chronic diarrhea. Gastrointestinal symptoms may be related to the direct inflammatory effect of HIV on the cells that are lining in the intestines. Some of the enteric pathogens that occur most frequently identified by stool culture or an intestinal biopsy. They usually are the name of those disorders includes Salmonella species, isospore, belly, Giardia lamblia or Giardia lamblia, cytomegaloviruses, and Clostridium difficile or C. diff, and avium intracellular. In patients with AIDS, the effects of diarrhea can be devastating in terms of profound weight loss. Usually, it is more than 10% of the patient body weight, and they lose fluid and electrolytes, and they cause electrolyte imbalances in their body, perennial skin excoriation because of the more frequent watery diarrhea, and weakness, inability to perform the usual activities of daily living. Candidiasis, oropharyngeal and esophageal candida or fungal infection are common in patients with HIV as well. Oropharyngeal candidias is characterized by painless, creamy, white plaques, plaque-like lesions that can occur on the buccal surface, hard or soft palate, oropharyngeal mucosa, or tongue surface. Lesions can be easily scraped off with the tongue depressor or other instrument, which is in contrast to lesions associated with oral hair, hairy leukoplakia. In women with early stage of HIV infection, Candida vulvogenitis usually present in the vaginal area, the same as in women without HIV infection. The appearance are white patches adherent to the vaginal discharge, associated with mucosal burning and itching of the mid to moderate severity and sporadic recurrence. HIV wasting syndrome is another manifestation that is defined as the involuntary loss of more than 10% of one body weight while having experienced diarrhea or weakness and fever for more than 30 days. Wasting refers to the loss of muscle mass, although part of the weight loss may also be due to loss of fat. The other disorder is oncologic manifestation, which are those with HIV or AIDS. Patient with AIDS, a patient are at higher risk for developing certain cancers. This includes Kaposi sarcoma, lymphoma, and invasive cervical cancer. KS or Kaposi sarcoma and lymphoma are discussed later in the our lecture, but cervical carcinoma is described in the gynecological manifestation section that you will learn in the next semester. So Kaposi sarcoma or KS is caused by human human herpes virus 8 or HHV8 that affects 8 times more men than women with HIV and may spread through sexual contact. It involves the epithelial layer of blood and lymphatic vessels. AIDS-related KS exhibit a variable and aggressive courses, ranging from localized cutaneous lesion to disseminated disease involving multiple organ systems. Cutaneous signs may be the first manifestation of HIV. They can appear anywhere on the body and are usually brownish pink to deep purple. This lesion may be flat or raised and surrounded by ecchymosis, which is hemorrhagic patches, and edema. A rapid development of lesions involving large area of skin is associated with the extensive disfigurement and significant body image issue. The location and size of some lesions can lead to venous lymphedema, and pain. Ulcerative lesions disrupt skin integrity and increases discomfort and susceptibility to infection. So these people are at higher risk for skin breakdown. And the plan should, the nursing care plan should cover or have plan for the skin protection as well. The most common site of visceral involvement are the lymph nodes,
gastrointestinal tract, and lungs. Involvement of internal organs may eventually lead to that organ failure or hemorrhage, infection, and death. Lesions of the AIDS-related kyphosis, sarcoma, you can see there is a picture in your textbook that you can take a look on those lesions. You can see the different color. Some patients may have lesions that remain flat, others may experience extensively disseminated raised lesions with edema. All right, let me see what else we have in here. So let's talk about AIDS-related lymphoma, which include both Hodgkin lymphoma and non-Hodgkin lymphoma. Non-Hodgkin lymphoma is more common, and yeah, people think if it's non-Hodgkin, it's not serious, but this is serious. This is more serious than Hodgkin lymphoma. AIDS-related lymphoma is usually aggressive. There are three main types: diffuse, large B-cell immunoblastic, and a small non-cleaved cell lymphoma. Symptoms include weight loss, night sweat, and fever, and the complete blood count might be abnormal, and a biopsy will confirm the diagnosis of lymphoma or cancer. Okay, yes, I covered this part too. Herpes immunointegumentary manifestation is herpes zoster and seborrheic dermatitis, and I think I talked about the gynecologic manifestation, which is genital ulcer, persistent recurrent vaginal candidias, pelvic inflammatory disease, and menstrual abnormalities. Going to the neurologic, fungal infection, Cryptococcus neoformans, or progressive multifocal leukoencephalopathy, which also cause the confusion, all of this, and depression and apathy are the neurologic manifestation. And looking at the patient with the neurologic, I'm just looking for manifestation of the neurologic effects on the cognition, motor function, attention, visual memory, and visuopatial function, peripheral neuropathy, and at the end, HIV encephalopathy. Very good. Let's go to the treatment of HIV and AIDS. So basically, the medication of choice are antiretroviral therapy, or ART, and which the goal is overarching to suppress HIV replication. So there is no cure. So far, there has been some genetic research that maybe genetically they can change the DNA, RNA of the virus. Haven't started yet, and some stem cell treatment, but what is now overall that are using for the treatment are ART therapy or antiretroviral therapy. This with the therapy, it just prevents from or suppresses the HIV replication. It reduces HIV-associated morbidity, and it prolongs duration and quality of life of patient. Also, the therapy with ART restores and reserves immunologic function. It causes maximally and durably suppressed plasma HIV viral load, which all cause the just reduce the HIV-associated morbidity, and also it prevents from HIV transmission. So, how we should assess a patient with HIV or AIDS? As I said, We need to basically assess the different system, because as far as we have learned about the HIV, during the stage 0, there is only 2 weeks of flu-like symptom, and then during the stage 1, which usually takes 5 to 10 years, and recently it takes more, maybe to 20 to 25 years, if the patient just follows the medication treatment and lifestyle changes, good nutrition. Now, basically, we need to identify the potential risk factor. We need to check the physical status of the patient, psychological status, immune system function, nutritional, respiratory, neurologic, fluid electrolyte, and the patient knowledge level, which is important. If the patient knowledge level, the lower knowledge level, is the poorer progression and shorter lifespan. So basically, when we do an assessment, we need to find the factors that puts the patient at high risk for death, the physical status, psychological, immune system functioning. That means that we need to have a set of laboratory tests, including CD4 plus. The patient nutrition is important, very important, because of 2 reasons. One is they usually have frequent diarrhea, and we want to make sure we educate the patient about the right nutrition to minimize the chance of the diarrhea and increase the patient nutrition and the needs of the patient. All right. So the next thing that we're going to talk about is how to prioritize the nursing diagnosis for a patient with HIV or AIDS. Usually, it's mostly what you might see in the hospital is a patient at stages of 8 in the hospital. So usually, if they are the symptoms are manageable, they do manage it at home. And once you have a patient in hospital, then you have to have a very great nursing diagnosis and prioritize based on the patient needs. Now, if I go over the priority, if the patient has diarrhea related to enteric pathogens, I would have a plan for that to treat, because as basically what you learned in the fluid and electrolytes, you know that the patient who is having frequent diarrhea or continuous diarrhea puts the patient at risk for fluid and electrolyte imbalance, and basically this patient is at high risk for body impaired nutrition, so as well. And we need to make sure to keep this patient free from infection, and make sure the patient effectively breathes and prevent from the any infection related to respiratory, like pneumocystis pneumonia. And we want to make sure increased bronchial which causes increased bronchial secretion, which needs the attention to keep that airway clear. Imbalanced nutrition, less than body requirement, is another priority. Deficit knowledge related to means of preventing HIV transmission is next priority, and social isolation. All right. Potential complication. We talked about all the complications that the patient can present to the hospital. All these complications are as a result of opportunistic infection, which is what? It could be in the gastrointestinal, it could be in the respiratory, it could be which with the respiratory, the patient would have impaired breathing or respiratory cause respiratory failure, and also cause wasting syndrome and fluid electrolyte imbalance. The other complication could be adverse effects of the medication. That is important to have the knowledge of each medication. If you're working in the oncology unit or in a unit that you might have the patient with HIV or AIDS, you want to know the adverse effect of each medication and educate the patient for those medications. So, what are the goals? What to plan for treatment? So, the goals for patients with HIV and AIDS may include resumption of usual bowel pattern, right? So, if the patient has diarrhea, you want to have a goal in place for resumption of usual bowel pattern, so prevent from the occurrence or frequency of diarrhea, absence of infection, improved airway clearance, improved nutritional status, increased socialization and expression of the grief, increased knowledge regarding disease prevention and self-care, and make sure the patient has no complications. So the absence of complication is the goal. So basically, to achieve the goal, what we need to do, we have to make sure assess for diarrhea, avoid food that are irritant to bowels, and administer medication. So what type of food usually irritates the patient intestinal system is the fiber. So the patient with HIV who is having frequent diarrhea needs to be educated about the type of food, the amount of the food, how much they have to eat, and what type of food will improve their nutritional status and also decreases the diarrhea. Like spicy food, they should avoid the spicy food. The food with high fiber and vegetables should be cooked for them to reduce the irritation to the intestinal system. And the medication, sometimes they have to be on anti-diarrhea medication to minimize the just void and having a frequent bowel movement. For the prevention for infection, we need to always monitor the patient's sign or symptom of the infection. So basically what we talk about infection, it could be in the could be candida in the patient pharynx and larynx and mouth. It could be in the respiratory system. It could be in the GI system. And for the female, it could be the genital area. So you, as a nurse, should monitor the sign and symptom of infection in any area. Monitor the lab test result for changes. So mostly we want to make sure the patient white blood cell count are monitored. Maybe you need to send the culture from the drainage or urine, stool, and sputum. And patient education is very important, and the patient family or significant others must be educated for the infection prevention. Continuing on nursing intervention to improve the patient airway, we need to do a respiratory assessment more frequently, pulmonary therapy every 2 hours. You know, they could be breathing, cough, exercise, and spirometer to improve the respiratory function and put the patient in semi or high Fowler position, and you might need to administer oxygen as needed. For the nutritional, you as the nurse want to make sure you monitor the patient weight, dietary intake. You should have a great track of intake and output of the patient, and check the patient serum albumin for nutritional status. Dietary consult is needed, and you need to instruct the patient for taking the supplemental nutrition. For So to improve the knowledge of the patient with HIV, usually you want to instruct the patient and family about the routes of transmission and prevention. This is very important. They know how to prevent from transmitting the virus to another person. They should avoid sexual contact with multiple partners. They must use condoms, and you will see what type of condoms is the latex condom they have to use. Usually the regular condoms that are available doesn't have enough barrier, so you can penetrate through that. So basically they need to use the latex condom. Do not use IV injection drugs, so you want to make sure if they are IV drug user, they need to know that they have to prevent from sharing the injection. You can also refer them to the different available clinics that provides them with the syringes. I know there are some in Maryland and Washington DC area that they can receive for free the needles and syringes to prevent from contamination. Usually the patient who, especially those who are recently or newly diagnosed with HIV, they feel a sense of social isolation. So we need to decrease that sense, and by assessing the pattern of social interaction, observe for behaviors indicative of social isolation, and assist the patient with identifying the resources. Resources that are available in the community, it could be home health care, nursing. We need to make sure that they monitor adherence to the therapeutic regimen. In the home health care nurse, they can always check on the patient for their complex wound care and respiratory care, and also make sure they take their medication. And the community programs that help with the transportation, shopping, legal, and financial assistance are available in the community for the patient with HIV, and hospice nursing during terminal stages provides physical and emotional support for the patient with HIV. All right, let's go to this question. It says, is a clinical syndrome that is characterized by the progressive decline in cognitive, behavioral, and motor function as a direct result of HIV infection. So going back to the lecture, it's asking you which problem caused this manifestation, which is HIV encephalopathy, or D is the correct answer. So let's see. Viral hepatitis is a systemic viral infection which causes necrosis and inflammation of the liver cell, which also produce a characteristic cluster of clinical or biochemical and cellular changes. And there are 5 types of viral hepatitis that we are going to discuss this in this lecture, which they cause liver disease, and they are hepatitis A, B, C, D, and E. Hepatitis A and E are similar in regard of the mode of transmission, which is fecal oral routes. I'm going to talk about that later. Which hepatitis B, C, and D share many other characteristics. Hepatitis is easily transmitted and causes high morbidity and prolonged loss of time from school or employment. The hepatitis C is also viral hepatitis that the total number of the cases in United States in 2013 was 2,138, which is one of those hepatitis that if it's not treated will cause cancer, into the liver cancer. My recommendation to you guys is to go over the table 49-4, which in this table there are comparison between the major form of viral hepatitis, and I highly recommend you to study that, which is going to be helpful for your exam too. So basically, when we talk about the hepatitis, there are two different types of hepatitis. One is viral and the other one is toxic and drug-induced hepatitis. We do not discuss the non-viral hepatitis in this lecture, but what we do, we are going to discuss over the viral hepatitis. Hepatitis A is the first hepatitis that we are going to talk. Typically, it is spread by poor hand hygiene and fecal oral. A child or a young adult acquires the infection at the school through the poor hygiene or hand-to-mouth contact or other close contact. The virus is carried home where they can just spread it through the whole family. An infected food handler can spread the disease as well, and people can also contract it by consuming the water or shellfish from sewage, which is contaminated the water. Outbreaks have occurred in the daycare centers and institutions as a result of poor hygiene among people with developmental disabilities. Hepatitis A can be transmitted during sexual activity as well. This is more likely with oral and anal contact or anal intercourse and with multiple sex partners. Hepatitis A is not transmitted by blood transfusion versus the hepatitis B and C. The incubation period is estimated between 2 to 6 weeks, with a mean approximately 4 weeks. The illness may be prolonged, lasting for 2 to 6 weeks. It usually lasts longer and is more severe in older people older than 4 years old. Most patients recover from hepatitis A. It rarely progresses to acute liver necrosis or hepatic failure, which results in cirrhosis and death because of the liver. Clinical manifestation of the hepatitis A, usually many patients are anicteric, which means what? Which means no jaundice or without jaundice, and symptomless. But when symptom appears, it shows of a mild flu-like upper respiratory tract infection with low-grade fever, anorexia, and early symptom is usually often severe. It's not usually severe. It is due to result from release of a toxin by the damaged liver or from failure of the damaged liver cells to detoxify an abnormal product. Later in hepatitis A, the patient may show some jaundice and dark urine may appear. Dyspepsia or indigestion is present in variable degree, marked by vague epigastric distress, nausea, heartburn, and flatulence. The patient may also develop a strong dislike to the taste or sense of cigarette or the presence of cigarette smoke and other strong odors. These symptoms tend to be clear as soon as the jaundice reaches its peak, usually within 10 days after its initial appearance. Symptoms may be mild in children. In adults, they may be more severe, and of course, courses of the disease may be prolonged in the adult. Management of hepatitis A starts with the prevention. For prevention, good hand hygiene, safe water, and proper sewage disposal. Going to the hepatitis B, unlike hepatitis A, the hepatitis B is transmitted primarily through blood, just the same as HIV. Hepatitis B can be found in blood, saliva, semen, and vaginal secretion, and can be transmitted through mucous membrane and breaks in the skin. Hepatitis B is also transferred from carrier mothers to their infants, especially in areas with the high incidence, like Southeast Asia. The infection usually is not transmitted via the umbilical vein, but from the mother at the time of birth and during close contact afterward. 49, a major worldwide cause of cirrhosis, and hepatitis B is a major worldwide cause of the cirrhosis and liver cancer. Looking at the chart for the 9.8 is talking about the risk factors, which are close contact with carrier of hepatitis virus, frequent exposure to blood product, healthcare worker, hemodialysis staff, oncology and chemotherapy nurses, personnel at risk for needle stick, operating room staff, respiratory therapists, surgeons, and dentists. So risk factors are hemodialysis, IV injection drug users, male homosexual and bisexual activity, mother to child transmission, multiple sexual partner, receipt of blood or blood products, a recent history of sexually transmitted infection, tattooing, and travel to or residence in area with uncertain sanitary condition. So manifestation of this long incubation period is 1 to 6 months. So the patient can be carrier during this 6-month period of time without having any symptom. Clinical manifestation or symptoms are insidious and variable among each patient. It is kind of similar to hepatitis A. Patient will lose the appetite, dyspepsia, abdominal pain, generalized aching, malaise, and weakness. Jaundice also may or may not be evidence of hepatitis B. The medication for chronic hepatitis B include alpha interferon and antiviral agent, entecavir or ETV, and tenofovir or TDF can be used. Bed rest is important, and nutritional support. As you guys are aware, vaccination is available, and all healthcare providers should be vaccinated for preventive measures. The vaccination should be provided for people who are at higher risk, which includes healthcare provider as well. Passive immunization for those who are exposed, like using the immunoglobulin. Standard precautions and infection control measures should be taken while you're taking care of the patient with hepatitis B, and a screening of blood and blood products should be checked before transfusing blood product to another human. Hepatitis C also transmitted by blood and sexual contact, including needle stick and sharing of the needle. So basically, when we talk about the hepatitis B and C, they are transmitted similar to the transmission mode is similar to HIV transmission, and hepatitis C is the most common blood-borne infection. It is a cause of third of cases of liver cancer and the most common reason for liver transplant. So basically, as I said before, hepatitis C is the most common cause of the liver cancer. For the risk factor, make sure to go over the chart 49.9 to read about the risk factor of the hepatitis C. As you guys may know, it is similar to HIV. So children born to the woman infected with hepatitis C are at higher risk. Healthcare and public safety workers after needle stick injuries or mucosal exposure to blood, and multiple contacts with the hepatitis C virus infected person, multiple sex partners, history of sexually transmitted infection, unprotected sex, past, current illicit IV injection drug users, and recipient of blood product or organ transplant before 1992, or those who have received the clotting factor who was concentrated before 1987 may have more incident of hepatitis C. Symptoms are usually mild. Chronic carrier state frequently occurs. So they are carrier, they're walking around, they have no symptoms, but they are people who can contaminate other people. The treatment or management of hepatitis C is antiretroviral, antiviral medication. Usually alcohol potentiate the disease. Medication that affect the liver should be avoided at that time. For prevention, public health program to decrease needle sharing among drug users is important. People should be educated about this, and screening of blood supply has to be monitored closely, and healthcare worker should make sure using safely the needles. Hepatitis D virus or delta agent infection occurs in some cases of hepatitis B. That means if the individual haven't diagnosed with hepatitis B, will not show any hepatitis or will not acquire hepatitis D virus, because the virus requires a specific antigen HBsAg for its replication, which usually after hepatitis B this will produce in the body. Only people with hepatitis B are at risk for this hepatitis, and hepatitis D is common among those who use IV or injection drug, patient who going under the hemodialysis, and recipient of multiple blood transfusion. Sexual contact with those who have hepatitis B is considered to be an important mode of transmission of hepatitis B and then D. The incubation period varies between 30 and 150 days, and the symptoms of hepatitis D are similar to those of hepatitis B, except that patients are more likely to develop fulminant hepatic failure and to progress to chronic active hepatitis and cirrhosis. Treatment is similar to the other form of the hepatitis. Currently, interferon alpha is the only licensed drug that is available in the treatment of hepatitis D virus infection. The rate of reoccurrence is really high, and the efficacy of the interferon is related to the dose and the duration of the treatment. High dose, long duration therapy for at least a year is recommended. Hepatitis E it is believed that hepatitis E virus is transmitted by the fecal oral route, principally through contaminated water in the area with poor sanitation. The incubation period is variable, estimate to range between 15 and 65 days. In general, hepatitis E resembles hepatitis A. It has a self-limited course with an abrupt onset. Jaundice is almost always present with hepatitis E, unlike hepatitis A. chronic form of the hepatitis E do not develop jaundice. Avoiding contact with the virus through good hand hygiene or good hygiene in general, including hand washing, is the major method of prevention of hepatitis E. The effectiveness of immune globulin in protecting against hepatitis E virus is uncertain, but certainly the hand hygiene is important. Okay, I think this is the last slide that I'm discussing this for this lecture, and I just recommend you, after listening to this, if you have any question, just write something on the comment area in the YouTube, and I will respond to your comments or question. Have a good one, and good luck with your exam.